ending the TB epidemic by 2030. Where are we as Busoga region? So I've already been introduced. I work with the USAID Local Partner Health Services project that is covering all the districts of Busoga. And my specific roles as the TB HIV advisor is to really strategize, lead the coordination of implementation of interventions towards the control of TB in the region. This presentation is going to be it's not going to be that long. I have a short outline here. We shall just look at the global context briefly, and the goals at global level. What are we looking at as globally? Then also the country. Dr. Mary has already mentioned something about the country context and what are our goals. What are we looking at? And what is the Busoga picture in relation to the global and country context? And what are we doing? How far are we? And what needs to be done? You know, a few thoughts from me, but the rest of the things of what needs to be done after listening to the presentation, I know your minds will be tickled, and you know we get what to be done. So to be able to know where we want to go, we must know where we are currently. You know, for example, if I'm going to Kamuli, I must know now that I'm at Buwenge. So this is basically what I'm going to present. As Busoga, we know where we want to go, then where are we? So basically that's the gist of this presentation. And then what do we need to do to reach where we want to go? So a bit of the global context, about 9.9 million people fell ill with TB in the year 2020, according to the Global TB Report of 2021. So you can imagine if 9 million people went into Bugembe Stadium, I don't know if they would fit there, but that is the picture. And until the COVID-19 pandemic, there had been significant gains globally in reducing the TB incidence, but the COVID pandemic really, among all the areas that were affected, the economy, whatever, also the fight against TB was affected in a way, because fewer cases were reported, higher number of deaths and all that due to the effect on access to TB diagnostic and treatment services all over the world. So the COVID pandemic somehow affected the gains that we had achieved previously. So just that brief global picture, where at international level are we aiming to go? So we have three kinds of strategies that you're seeing there. We all know the Sustainable Development Goals, and in SDG number 3, that's where we find the strategy to end by 2030 the epidemics of AIDS, TB, malaria, and other neglected tropical diseases. So that's where TB also falls. So there is that global aim. The minds in the whole world are thinking to end TB by 2030. And the WHO also has an end TB strategy. The strategy of ending TB by that time through reduction in incidence. We all know that incidence is the new cases of a disease that develop in a given population in a given year. So their targets to reduce the incidence. If in Uganda 90,000 people develop TB every year, by 2030, can we have reduced that number by 80%? You know, when we do that, then we shall have achieved the goals of the NTB strategy by WHO. Then the NTB strategy globally by WHO also aims to reduce the number of deaths from TB by 90%. You know, that's the target. TB still kills people. And in order to end TB by 2030, the globe, the whole universe aims to reduce the death of TB by 90% compared to the baseline year, which was 2015. You well know the SDGs were set after the Millennium Development Goals. The SDGs came 2015. So the baseline year is 2015. So by 2030, compared to 2015, we want to have reduced the TB death by 90%. So the other strategy is to really make sure that no households are affected by TB in terms of catastrophic costs by that time. So in 2018, again, there was a UN high-level meeting. We are looking at the global aims so that we cascade it down from the global to the country, then to our region. So the UN also had a high-level meeting, and they sat and agreed on a number of targets to also end TB, as you can see them there. To make sure that 40 million people are put on treatment by the year 2022. So these are like interim targets to make sure that by the time we reach 2030, we've really had a dent on this TB epidemic. So they are there, as you can see them there. I won't spend a lot of time on those. So those are the kind of global goals and targets to end TB. So of course, there's the NTB strategy that I've been talking about, and it has those milestones that I've talked about, and there are key pillars in that strategy. And these are things that are supposed to guide the nations and whichever people as they strategize to end TB. One of them is integrated patient-centered care, subcomponents, making sure we diagnose TB early, we put people on treatment, we do TB HIV collaborative activities, then we also provide prevention to persons that are high at risk. And I hope we all know that one of the most risk populations for TB are people living with HIV, the contacts of TB patients, and the like. Then we must form bold policies. I know a number of us are policymakers. Bold policies, including political commitment and allocating adequate resources for TB care and prevention. I don't know if you are a DHO or a CAO on this forum. At your level, what role are we playing in terms of really allocating resources to end this epidemic? The other thing is, of course, engaging the communities, civil societies, and private care providers, and ensuring social protection and all that, and of course, research. So these are the strategies at global level which need to be worked on in our micro units at country and regional level to ensure we end TB. So like Mary said, I won't spend long on this slide. She already gave a background that Uganda is one of the 30 high TB HIV burden countries. What does this mean? Uganda is among the 30 countries that contribute to about 85% of the global burden of TB. You imagine all the countries in the world, I don't know how many they are, around 200. So the top south, there are only a few countries, about 30 of them, that contribute 85% of the global burden of TB and HIV, and Uganda is among them. So like Dr. Mary said, about 90,000 people fall ill with TB annually every year, and we are only identifying about 70 to 80% and starting them on treatment. That means we are missing that critical 20%, which is continuing to fuel the epidemic. So any undiagnosed, untreated TB patient now infects others, and now the epidemic remains. So if there was a way of capturing all the TB patients that are out there and put them on treatment, the TB epidemic would actually end within a day or 6 months. But these missed TB patients that are out there in our communities now continue to fuel the epidemic, and our efforts must be geared towards finding those. So at country level, having looked at the global level and the targets that have been set globally, we are implementing the National Strategic Plan for TB and leprosy control 2020-2025. It's quite new, and it's well aligned to the global targets that we've just gone through. And the overall goal is to reduce the TB incidence by 20%. Like Dr. Mary said, we were at 200 when this National Strategic Plan was being developed, meaning that for every 100,000 people, 200 in Uganda, 200 of them develop TB every year. That's what this means, incidence. So the aim of this strategic plan, the goal is to reduce that by 20%, so that by 2025, we are at 160. So this is the national goal, baby steps, step by step, so that maybe after 2025, we could now further set another goal to reduce it further. Yes, so the National Strategic Plan, of course, has different strategic objectives to make sure that we reduce the incidence. You can see one of them is to increase TB awareness in communities. You people, you could get shocked if you went to Ginger Central Market and probably asked people about TB. You would get shocked that people maybe think it is witchcraft or other things. So there's a role to play here to create awareness among TB, among the community, so that they are able to demand the services. It is a key strategic goal for the country. The other goal for the country, we are now at country level, is to really increase TB preventive treatment. We know there are several ways of preventing TB, one of them being BCG vaccination, which is given at birth, but that is not enough. It has been proven that that only significantly contributes to reducing severe disease, but still people get TB. So there are other preventing ways, including infection control measures, and then this TB preventive treatment. What do we mean by TB preventive treatment? It is treatment given to people who do not yet have TB, but they are at very high risk of getting TB. So you're preventing them from getting the disease. And these high risk groups include people living with HIV, maybe the contacts, people who live with TB patients. So the nation aims to increase TB preventive treatment to eligible people, like I've mentioned, to greater than 90%. So we do not want to only look at the patients alone. We also want to prevent TB before it occurs. Like the old adage goes that prevention is always better than cure. So there is a preventive objective in that. We want to improve treatment coverage from 76% in 2020 to 90%. This means that everyone who has TB out there, at least 90% of them should access treatment. That's really the basic one. The other objective is to build efficient and effective systems to ensure quality, equitable, and timely TB and leprosy services. Of course, you're seeing leprosy there. The national program covers both diseases. And strategic objective number 5 focuses on leprosy. And then number 4 is to increase TB treatment success rate. The patients we are getting and managing to put them on treatment, are they successfully completing their treatment? Because that's another hassle. Because there is an emergence of drug-resistant TB if these people are not taking their medicines well. So, and before the strategic plan, we are not doing so well. Our TB treatment success rate was only at 72%, but by 2025, we want that over 90%. This means that when a TB patient has been identified and started on treatment, they should complete their treatment for 6 months and declare cured. So we still have challenges of people getting lost along the way and not completing treatment, and that is a recipe for disaster. Things including drug-resistant TB, death, and others. So that's where I want to go as a country. We've seen where the globe is heading in terms of TB. We've seen where the country want to head. So as Busoga, where are we? So this slide is a bit busy, but I will explain it in short terms. These are the districts in the Busoga region and their respective case detection rate. So case detection rate, what do we mean? We mean that in a given population, let's say of Ujiri district, like you're seeing there on top, there is an estimated number of TB cases that are estimated according to epidemiology in that population of Ujiri. So, so case detection rate is basically a function of, as a Ujiri district, how many TB patients have you been able to identify from your community, from your population, and put them on treatment? And it is in terms of percentages. So if you're seeing the first column there, it is in quarters. Ujiri district is estimated to identify 194 TB cases every quarter. These are 3 months. Every 3 months, Ujiri district is expected to identify 194 TB cases and put them on treatment. When they do that, we shall end TB by 2030. But is the Ujiri doing so? So you can see in the quarter of January to March 2021, Ujiri expected to identify 194 and put them on treatment. They only managed to find 110. And that was a score of 57%. So those colored in red you're seeing there are the achievement, and anything below 90%, because we say it has to be 90%, that is a red. That means Ujiri missed about, if we do the subtraction in that quarter, that means about 90 TB cases stayed out there. And what they are doing is they are just spreading the disease and multiplying those who have TB. So you can see throughout the quarters, the district of Bujiri has not been doing so well in terms of TB case detection rate, hence the red scores. So you can see, I've given an example of Bujiri, but you can see the rest of the districts. So if you're a stakeholder, health stakeholder in one of these districts, now we need to pose the questions, why? Why are we not identifying these TB cases that are in our community? So as you can see, it is the districts of Iganga. I think it is Iganga that has been doing quite well. You can see it is in green throughout. Greening means you're meeting the target of identifying 90% of the TB cases that are estimated to be in your community. So you can see it's basically Iganga and maybe Ginger City. This is probably explained by maybe these people have big hospitals, and this is where people come and all that kind of thing. And it speaks to really improving accessibility to TB services. Because when you go to a district like Buyende, which has no hospital, which has few TB diagnostic and treatment centers, and you're seeing Buyende is throughout in red, their cases are still out there in the community. So this speaks to the point that increasing access to TB services, diagnostic services, treatment services, really helps in this fight of picking the TB cases. So this is the picture in our Busoga as we march towards 2030. So wherever you see red, know that we are missing TB cases. They are out there in the community. This is the message from this slide. How do we compare with other regions in the country? Like I told you, the target is 90% to pick the 90% of the TB cases that are out there in our communities. So this is how the map of Uganda is. As you can see, most districts have really moved. They're actually picking these TB cases from their communities and putting them on treatment. But I've circled Busoga in blue out there. That's our region. You can see most of our districts are still in red, meaning that we are missing TB cases. When we miss them, that translates to increased transmission, because wherever a TB case is and it's not on treatment, they are simply transmitting to other people. So you can see Karamoja is doing quite well in picking the TB cases that are estimated. West Nile, the western part, the far western part of Uganda. So this middle belt of Busoga, Bukedi, and maybe Teso, a bit of Ankole here. So you can see there are TB cases that we're actually missing and hindering the fight to end TB by 2030. So that's how we compare with the rest of the country. And you can see that we are not doing well on that aspect. So the bottlenecks to low case detection, these are my opinions, but you have others. And this is a discussion. We are not doing enough screening at health facilities. If there are DHOs on this forum, we want everyone that is coming to health facility to be screened for TB. Even if you are a DHO and you've come to do support supervision, they should screen you for TB. That's what we call active case finding, as opposed to the passive way of waiting for the patient to volunteer the symptoms. So when we take the active approach, we shall not miss the TB cases. Low index of suspicion among health workers. There are some cases of poor attitude of health workers towards TB. We are not utilizing our technology very well, like we shall see in the next slide. Low community awareness and all that. So these are some of the things we think are contributing to that, but you could be knowing more. TB-HIV integration, we know TB and HIV are like cousins, like sisters, and the national policy is that we should really provide services in an integrated manner. And what do we mean? All TB patients must know their HIV status, and you can see the first stack of graphs is how are we doing in that? Are all our TB patients knowing their HIV status? We're doing quite well here. No, this is the Ministry of Health. That's why you're seeing MOH. Then on the right-hand side is Busoga. So we want to compare. With the rest of the country, how are we comparing? So the first kind on the left is the MOH, then the right hand is Busoga. So you can see percentage of TB patients who know their HIV status. We're doing quite well. As Busoga, you see we're at 99%. There's that 0.1% that is eluding us. every TB patient must know their HIV status as part of the integrated package of services. Now, the percentage of TB patients who are HIV co-infected, you see nationally, it is around 30%. It has been reducing. I can tell you about 10 years ago, it was almost 50%, but due to several efforts, you can see it's really going down. Nationally, around 30%, TB patients co-infected with HIV. But for Busoga, I think we are doing great work. Our region, the prevalence of HIV among TB patients is lower from the program data. You see, by the last quarter, it was just 25%. So we are quite ahead of the country on that kind of indicator. The reasons for this could be maybe our lower HIV prevalence and maybe several other efforts, but we are doing quite well on that. And our TB patients and who are co-infected with HIV should all 100% be on antiretroviral therapy, and we are performing around 99%. So that little gap of 0.1% that is missing be about data issues and a few things, but in terms of integration, we're doing some work, some good work there. How are we performing in terms of the patients who we start on treatment? How is their success rate? This is an indicator for quality of our TB program. And the target is again 90%. So as you can see, we are not doing so bad over the last 4 quarters. You know, a green is 90%, anything below 75 is a red. So you can see our districts are really trying to retain the TB cases and ensure that they complete treatment. But we are not yet there, that 90% target. If you have identified 100 patients, at least 90% of them should complete treatment successfully. So you can see over the last quarter, October to December, it was a few districts of Kamulilu, Kamayuge that achieved the 90%. There were particular issues in Buyende and Kaliro, maybe probably due to high loss to follow up, defaulters, and maybe some deaths. So how do we compare with the country? In this particular indicator, we are not so bad. You can see our district circled in red there, quite some greens and yellows, no red. So we are doing some commendable job in terms of retaining our clients, and that's good in terms of ending the TB epidemic. The other quality indicator about cure rate is we are not doing so well on this. Cure rate is about, by end of 6 months treatment, has someone cured? Have they done a test and I know it has become negative? So we are doing not so well at 65%. And this is really an indictment on our laboratory systems, because most of our patients complete treatment, but they have no test result at the end of treatment. So there's no way they can be assigned an outcome of being cured, much as they have completed treatment. It's technically defined like that. So the issue is our laboratory systems, and we are doing, as a project, like I said, I'm working with the LPHS MJAP. We are doing several interventions to make sure this improves. How are we doing in terms of MDR-TB surveillance? Like I told you, there's a monster of drug-resistant TB. And the majority of drug-resistant TB is actually man-made. Man-made, when you don't treat the normal TB very well, it turns into resistant TB. Must put in efforts to do surveillance for drug-resistant TB because it's a monster. It's more expensive. You know, someone did a research that most MDR-TB patients are actually even depressed because treatment is longer, it's more expensive and all that. So in terms of surveilling for MDR-TB, how are you doing? One of the proxy indicators of how we are doing well on surveillance for MDR-TB, MDR means multi-drug resistant TB, is how are we utilizing our GeneXpert. GeneXpert is technology that helps us diagnose TB and also picks resistance. So we have several GeneXpert machines in the Busoga region. District currently at least has one machine, which these machines are supposed to help us really pick the drug-resistant bit of TB. But how are we utilizing them? The standard is that every TB suspect who we call presumptive TB clients should access a GeneXpert test. Even if there's no GeneXpert machine at that facility where they are, there are systems to refer the sample. But how are we performing in terms of that? Really doing badly. That's why you're seeing this red. You know, uh, patients have come. They are to let me use an example of Narisoiji Health Center 3 in Namutumba. The sample has been collected. They have tested with microscopy. This sample, there is a system how it should end up at the Nsinze Health Center 4, where there's a machine to test and ensure that there's no resistance. So we are not utilizing that very well. It's something where we are struggling, and this will hamper our efforts to end TB by 2030, because we don't want to get into the resistance bit of the TB. And the graph on the right-hand side shows actually about referral. Of the tests that we performed in Busoga, how many of them had been referrals from other sites? Because these machines are not everywhere. They're in selected high volume centers. So these other lower facilities are supposed to benefit from the service through referral. There is a hub system, you know, where samples are referred. You can see that the referral of these samples to test for resistance through this gene expert is not doing well. The green bar is the total tests with gene experts that were conducted. The blue bar is about those that had been referred from other sites as an effort of surveillance for MDR. So it is something we need to improve as we. So the MDR-TB case detection, the Ministry of Health estimates a certain number of MDR-TB cases in our populations. For example, in Busoga, every 3 months, it is estimated that we should identify 33, 34 MDR-TB cases from our population of 4.6 million.